Today's module will discuss rib intervention. The objectives of this lab are to present best evidence for management of rib cage dysfunction with use of case examples, demonstrate manual therapy techniques directed towards the rib cage articulation and soft tissue, and develop a home exercise program for identified rib impairments. Referring back to our anatomy, we have four main articulations when referencing the ribs. Costotransverse joint, which is the joint formed between the rib and the transverse process. Costovertebral joint, which is the joint formed between the rib and the vertebral body. Costosternal joint, which is the joint formed between the rib and the sternum. And the costochondral joint, which is the joint formed between the rib and the cartilage. These joints move to allow for movement both during respiration as well as thoracic spine range of motion. When observing respiration, the upper ribs will move in movement patterns similar to a pump handle, where the anterior-posterior diameter of the rib is either increased or decreased. The middle to lower ribs will move in a bucket handle pattern, where the lateral portion moves upwards and downwards, changing the transverse diameter of the rib. The bottom two ribs move in a caliper motion, in which both the anterior-posterior and transverse diameter is increased. These articulations also need to be mobile to allow for full range of motion of the thoracic spine. The muscle system is also worthwhile to review. Clinically speaking, it would be difficult to find a patient with rib and thoracic pain that does not have impairments and/or pain generators in both the joint and muscular system. More often than not, we need to treat both systems for full pain relief and restoration of function. As you can see in the upper left image, the deeper muscle groups lay extremely close to the costotransverse joint. Dysfunction in this joint may cause or be due to multifidus spasm or dysfunction. Another important point to observe on this slide is the attachment site of most of the intermediate layer of the thoracic muscular system, as seen on the image on the right. This explains why core exercises may be required for those expressing rib and thoracic pain and dysfunction. So what subjective complaints may cue you into looking at this region for possible sources of pain and impairments? Common mechanisms include trauma, muscle spasm, muscle sprains, joint strains. Pain patterns include the posterior thoracic, chest, under the scapula, and posterior lateral shoulder. As depicted in the image on the right, the intercostal nerve runs between the ribs and can be subject to dysfunction easily with pathology in this region. This would create a horizontal band of pain around the rib cage. These suggestions are not hard and steadfast, but are key items to cue you into exploring or screening this area. With four potential joint pain sources, along with muscle pain, you can see how teasing out the exact pain generator may be a bit difficult. As we have learned in other body regions, we may not need to tease out the exact pain source, but rather utilize both biomechanical and neurophysiologic mechanisms of manual therapy to treat our patients. Identification of rib dysfunctions. Review of objective measures. You have already been exposed to assessment of the thoracic spine and rib in lab, but I wanted to review key items to understand before we move forward. As we know from the lumbar spine, we have anatomical variances throughout our population. You may find abnormalities through palpation, but they are only relevant if you have a positive movement test. A positive movement test can either be a positive finding throughout your springing assessment and/or a positive finding on other mobility assessments. Again, we only name dysfunction and address it if a palpation finding matches a positive movement test. This is the exact decision-making we used to treat the SI joint. You will get a chance to practice palpation in lab, but wanted to reference some common landmarks to be acquainted with. Anteriorly, when we palpate the ribs, we reference the angle of Louis as the location of the second rib. Posteriorly, we will palpate the ribs with the inferior angle of the scapula as the reference point. Also of note is the rib angle being 2 to 3 thumbs breadth laterally to the spinous process. While you are palpating, you are looking for pain, equal spacing between ribs, prominences, and depressions. Rib springing is an opportunity to establish a positive movement test by a finding of hypomobility and/or pain. This can help rule in or rule out the rib articulation as a pain source. Another opportunity to establish a positive movement test is through mobility assessment. With this test, you are looking for symmetry between sides and throughout a side. Gently place your hands over the patient's ribs and ask them to breathe while you assess for any asymmetries. Now on to naming what you find. With this region of the spine being far less studied than that of the cervical spine or lumbar spine, we do not have clinical practice guidelines or treatment-based classification systems to follow. Thus, we go off of our knowledge of anatomy, biomechanics, and principles of manual therapy. A common diagnosis that occurs in the ribs is a joint sprain, leading to possible subluxations. Ribs can be subluxed anterior, posterior, inferior, or superior. Again, I want to stress that no one's anatomy is identical. We may have a prominence, but if that does not match a positive movement test and a pain pattern, then it is an irrelevant finding. A relevant finding of an anterior rib would be a prominence anteriorly with a depression found at that same level posteriorly. The patient must also have a positive movement test at that level. A relevant finding of a posterior rib is a depression anterior with a prominence found posterior at that same level. They also must have a positive movement test at that level. Here is where things can get a little tricky. If a patient has an inhalation dysfunction, also known as internal torsion, it means that they are stuck in inspiration, also seen as stuck superior. What you will find on your exam is a rib that cannot fall during exhalation. This is also seen as an increase in space between the rib in question and the rib below. If a patient has an exhalation dysfunction, also known as external torsion, the rib cannot move superior on inhalation. An asymmetry of space is noted, with the increased space this time being between the rib in question and the one above. Now that you have sorted all through all these possible subluxations, I want to turn your attention to an opinion piece written by Jam in 2015 questioning if ribs really go out or if it is just swelling or protective muscle spasm that we are palpating. Our treatments work, but may work to ease muscle tone and pain levels versus actually reducing a subluxed joint. This should put your mind at ease if you are in the clinic and forgetting which technique is for which subluxation. Try general mobility first, and if unsuccessful, work on specific direction of techniques. A common dysfunction we see in the first rib is it being stuck in elevation. Oftentimes, this is an atraumatic onset. The scalenes have a superior pull, thus if they are dysfunctional, they impart dysfunction on the first rib. This dysfunction can be seen in many pain syndromes of the cervical spine, shoulder, and peripheral nerve entrapments, most common being thoracic outlet syndrome. Assessing for first rib dysfunction is much easier than other rib subluxations. We will practice this technique in lab. I'd like to present a case to you to further your understanding of how a patient with first rib dysfunction may present. Your patient is a 34-year-old female with pain and neck stiffness, occasional elbow and forearm pain, as well as pain in the hand with paresthesias. Aggravating factors include driving and checking blind spots, as well as prolonged sitting. Objectively, you have a positive cervical rotation lateral flexion test, a positive on your ulnar nerve mobility test, decreased cervical rotation, decreased length of levator scapula and scalenes, and a hypomobile CT junction. Please pause this video and take a second to create a list of possible treatment items. I hope some or all of these made it to your list. Do not worry if they did not, however, as we will address this more in lab. Hypomobility, referred pain, and regional interdependence. In those patients where a subluxation is not observed and hypomobility exists, we will select springing techniques, mobilizations, and manipulations. The next case to further your understanding. Your patient is a 40-year-old female, status post right humeral fracture, 5 months prior. She complains of posterior lateral shoulder pain, pain over the AC joint, and periscapular pain. This is brought on by overhead pushing, reaching forward and to the right, and pulling horizontally. She has pain and stiffness with rotation to the right. She denies pain with breathing. She describes pain as dull and achy. Objectively, you find pain with cervical and thoracic extension, hypomobility of ribs 1 through 3, and hypomobility of the upper thoracic spine. You palpate a trigger point on the right rhomboid. Please take a moment to list the possible treatment options. I hope some of these items made it to your list. This patient would benefit from mobilization or manipulation to the upper ribs and upper thoracic spine, trigger point work through strain counterstrain on the rhomboids, as well as exercise to promote mobility of the thoracic spine and ribs, as well as scapular mechanics overhead and with pulling. You will learn this variation of a supine thoracic thrust to address the rib hypomobilities. As always, manual therapy should be followed by active range of motion introduced in the clinic and then followed up at home. This is one of the many techniques we will discuss in lab. In the next few slides, we will talk about how to treat rib dysfunctions as they pertain to subluxations and sprains. Though it may be hard to believe, you have the knowledge and skill set to treat these patients already. We can use what you have already learned in other joint regions and apply it to these patients. The one unique aspect in treating the ribs is it is a closed loop system. Thus, we can use that to our advantage. If the patient is too irritable to directly treat the joint in question, we can treat the other joints in that closed loop system. In treating joint pain and/or hypomobility, we can use joint springing, remembering our grades of 1 through 4. We can use mobilization with movement, where we apply a sustained glide and ask the patient to move through a pain-free range of motion. And we can use joint manipulation for its biomechanical and neurophysiological effects. At the level of the muscle, we can use the strain counterstrain techniques you have learned. We can also use PNF patterns to relax or inhibit a muscle, as well as active release techniques. Regarding exercise, we want to maintain range of motion through active range of motion and stretching, ensure good postural muscle activation and endurance, balance strength between anterior and posterior muscles, as well as left side and right side, and also issue core exercises as you learned in the lumbar stabilization lab. To help you better understand the presentation and management of rib sprains, we will use this case. Your patient is a 21-year-old female with insidious onset of chest pain beginning 1 year prior. She is a college rower, meaning she moves into flexion, left rotation, and left side bending often. Aggravating factors include rowing, running, deep breaths, and horizontal adduction of her shoulder. Objective measures include full active range of motion of the cervical spine, thoracic spine, and shoulder, an increased kyphosis in resting posture, swelling at the third and fourth costosternal joints, slight anterior protrusion of the left costosternal joint, crepitus and cavitation with active shoulder adduction, hypomobile T1 through T4 facet joints, and hypomobile T3 through T4 costovertebral joint. Palpation revealed the lateral interspace between ribs 3 and 4 to be tender and a displacement for the third rib on the fourth rib. This means that the space between 3 and 4 was decreased. You also found the length of the pec minor was limited on the left. Please take a second to create a list of possible treatment options. I hope some, if not all, of these options are on your list. This patient may benefit from addressing the impairments of her anterior rib, soft tissue restrictions, hypomobility, along with exercise to address imbalances between muscles of the front and the back, as well as the right and the left side. This is a technique we will get a chance to practice in lab. With this technique, we are trying to address a rib that we find to be anterior. Thus, we will be pressing posteriorly on the rib and then ask the patient to contract their serratus anterior to elicit a posterior pull on the rib. This technique will also be practiced in lab. A manual technique for exhalation dysfunction. If a person has an exhalation dysfunction where the rib cannot move up during inhalation, we simply ask the patient to inhale and use the upward pull of the pectoralis muscle to assist in the upper ribs. In the middle to lower ribs, we need to assist with a bucket handle motion. Thus, we pull up on the lateral border of the rib to assist with inhalation as the patient inhales, and then hold it there while they exhale. And one final case to further your understanding. A 55-year-old male slipped on the ice 3 days prior, landing on his chest with his arm trapped underneath. He slept off the initial soreness, however, is now noticing a dull pain posteriorly and under his scapula. This pain has also moved into his chest. You observe a prominent rib posteriorly with hypomobility and pain on that segment. You also find an increase in space between this rib and the one below. It does not fall during exhalation. Please take a couple seconds to create a list of treatment options. I hope some of these made it to your list. This gentleman would benefit from addressing the subluxations you found, as well as education on active range of motion. This case differs from the one before in that it is a traumatic onset versus overuse. We may not need to be as specific with our exercise selection and balancing sides as well as front and back, as we were for our rower, as his asymmetrical strength or poor movement patterns did not cause his initial complaints. For a posterior rib, we will push the rib anteriorly and then use the force of the pectoralis muscle to further pull in an anterior direction. This technique will be practiced in lab. For inhalation dysfunction, we want to encourage the downward motion of the rib. Again, in the upper ribs, we want to facilitate a pump handle motion. Thus, we will hold the rib down during inhalation and then follow it more inferior as the patient exhales to engage a new barrier. For the lower ribs, to facilitate the bucket handle motion, we will perform the same movement, only further laterally along the rib. Rib mobilization with movement for sprains. Remembering Jam's piece, it may be beneficial for you to start with a more generalized mobilization with movement. Both of our patients may have benefited from this technique as well. This technique has proven beneficial in some case reports as well as anecdotally. We will practice this technique in lab as well as how you can issue it for a home exercise program. And here are references for your benefit. I thank you for listening to this module and hope you find it helpful in active participation in lab.